Welcome everyone to Women's Health Tech Wednesdays. I am your host, Nina Joshi. That would like to bring on our guest for today, Effie Andrikopoulou, the Associate Professor of University of Washington. As you know, we love questions here at Women's Health Tech Wednesdays. So if you have any for Dr. Effie during the conversation, please use the Q&A or the chat feature, and I will make sure that we get to it. With that, thank you so much for being here today.
Hi, Nina. Thank you so much for having me. It's always such a pleasure joining the Hit Lab community. I always feel so energized after every time I interact with you guys. So very
Awesome.
excited and honored to be joining you.
Oh, we are so excited to have you. Thank you so much for those kind words. And Dr. Effie, maybe a great place for us to start, for our audience to get to know you more too, is if you could just share a little bit of an introduction, a background, kind of your career journey thus far.
Absolutely. My name is Effie Andrikopoulou. I'm a cardiologist with an expertise in cardiovascular imaging and cardio-oncology. I'm currently an associate professor of medicine with University of Washington in Seattle. And my passion has to do with using innovative tools and solutions that could be AI or not, to make sure that all of our patients get the highest quality of care equitably without any compromises. That means meeting every single one of our patients where they are and based on what they need the most. I'm also very passionate about representing women in cardiology and in leadership positions as well as in health tech. Sadly, women are still underrepresented in both these worlds. And I'm very passionate about promoting the female presence in those fields.
That's incredible. I love that. And I think there's so much to cover with all of those passions of yours. You know, the minute I found out about your passion for imaging, the first thought I think for a lot of people's mind was technology. Um,
Yes.
I'm so curious, what really motivated you to kind of combine this, this passion for cardiology, the discipline, but also emerging technologies like AI and others kind of in your career?
Absolutely. First of all, the reason that I first went into cardiac imaging was way back when I was a first-year cardiology fellow. My very first rotation was in the echocardiography lab, and it really clicked with me and it resonated with me so much because a lot of imaging is based on math and physics and algorithms, which I love. I've always been a math and physics nerd ever since I was little. So I really loved the fact that I could make sense of this world by by going back to math and physics principles. So that was the reason that I was attracted to imaging to begin with, plus the fact that I realized that I could learn so much about someone, about a patient or an individual if they didn't end up having heart disease, but I could still learn so much about their cardiovascular health and physiology without ever seeing them in real life. And I also had incredible mentors who inspired me to go into cardiac imaging. And then when I trained and did my dedicated 2 years of cardiac imaging after I completed my cardiology fellowship, I got exposed to cardiac CT, cardiac MRI, cardiac PET, and this multimodality world and how each one of these modalities complements each other really made me opened up my eyes and made me understand the future of cardiology, which I think is based a lot on non-invasive multimodality imaging. So now to bring this into the technology component, a lot of us probably here know that the number one adapter of tech and innovation in medicine is radiology, by far. They're the highest adapters. They have the highest number by far of FDA approved devices and tools and solutions that have been approved for use in radiology workflows. Number two is cardiology, and that's because of cardiovascular imaging. and the intersection between cardiology and radiology. And I will say I am a millennial. I did grow up playing video games. So I love that tech aspect. I love
Yeah.
that it's just I feel like uh, thinking outside of the box. There's so much that we can do with tech and with responsible tech and responsible AI and responsible innovation. There's so much that we can do, and we are now given a new opportunity to make things right
Mhm.
by designing and implementing tech and AI and innovation in a responsible way in
Right.
our clinical workflows, be that imaging or not. Um, I feel like now with the advancements in AI and tech, we are given a second chance
Mhm.
to make things right.
Absolutely. That is how powerful. There's so many things I loved about what you were sharing. I think, one of them speaking to how imaging is really like storytelling. It could tell you so much about someone and how technology is almost like it's like it goes so hand in hand with really the possibilities that exist in this space. And of course, on that note, I have to ask you, how is I think we talk I think there's a lot of conversation. I think there's a lot of excitement on AI specifically, but of course, we know that there's so many other types of technology too. But how is AI and other technologies really kind of changing or disrupting cardiovascular imaging? What are some of the big areas of opportunity that you're seeing in the broader tech space?
Absolutely. Like I said, cardiology is number two in adoption due to a big part in the imaging aspect.
Right.
That plays a huge part in our everyday work as cardiologists. We base the vast majority of our management, risk stratification, patient monitoring on non-invasive imaging. And we now have so many different tools. We have the traditional workhorse of cardiovascular imaging, which has been echocardiography,
Mm-hmm.
nuclear stress testing. It used to be just one specific camera. Now we have more than one. We have PET cameras um,
Wow.
that have much higher sensitivity, resolution, and diagnostic accuracy. We have cardiac CT, cardiac MRI. Um, I will say that there's a lot of advancements going on in every single one of them.
Mm-hmm.
I will say that if we can pick one to highlight a little bit today, I would probably go with cardiac CT. Um, Maybe some people from the audience have heard of companies and tools like HeartFlow for FFR, fractional flow
Mm-hmm.
reserve CT, and Clearly, which focuses a lot of AI-enabled quantification and characterization of atherosclerosis that
Wow.
develops in the heart vessels,
Right.
um, meaning cholesterol plaques and cholesterol blockages that develop in the heart vessels. And to me, these are um, these are the immediate next steps in terms of personalizing management of cardiovascular disease, in particular coronary heart disease, the
Right.
type of disease that might cause heart attacks.
Mm-hmm.
So that's one big highlight. The other big highlight, since we are focusing on women and women's heart health, is the use of PET, of cardiac PET imaging for
Mm.
detection of microvascular disease in women, or
Wow.
for diagnosis of heart attacks that
Mm-hmm.
are not because of obstructed arteries,
Mm.
which is traditionally what we have been taught of in all throughout med school and throughout our clinical training. But
Yeah.
this was because of evidence that was based mostly on men, not on
Mm.
women. We are now increasingly recognizing that for women, sometimes their chest pain is not because of heart attacks and blockages in big arteries, but because of cholesterol plaques and disease that develops in the tiny, tiny arteries that we can't visualize, that we can't see, but we
Right.
can assess them using PET imaging.
Right.
So a lot of innovation in those two areas. And I
Hmm.
do want to take a quick second to also mention an emerging gatekeeper for further imaging in heart
Yeah.
disease. So EKGs, which we all know, everybody can get an EKG. I mean, now even with our smartwatches, we can get an EKG. But in any doctor's office, from your primary care doctor, urgent care clinic, standalone ERs, any clinical practice can and should be able to get an EKG.
Yeah.
Well, now we have AI algorithms, some of them FDA approved,
Hmm.
to identify people who are at risk for different types of valve disease or heart dysfunction. And
Hmm.
so the EKG is now getting a new and emerging role as the gatekeeper for further imaging that can
Interesting.
hopefully be done in a more timely manner and help us
Right.
identify disease in a more timely manner in hopes that this will help us treat it much, much better further down the line. You know,
Absolutely.
so yeah,
That's amazing. I think the two things that for me stood out the most was what you just said about how you're able to move all of the diagnostics upstream, right? And that much quicker, which is phenomenal. And then also about women, I've heard many times that like heart attacks present differently in women, but being able to use imaging almost as like an equity to kind of be able to bridge that gap, I think is so exciting.
exactly. And not to mention everything, because imaging is not in siloed. We don't just decide to get a test done just because.
Hmm.
There's also labs that we check that support our decision making. And there have been studies, recent studies, that have shown that labs that we have been traditionally checking to see if someone might be having a heart attack, those are
Hmm.
called high sensitivity troponins.
Hmm.
A group looked at men versus women and seeing if we should be using different cutoffs for what's abnormal for this kind of blood test that
Yeah,
identifies heart attacks. And they
right.
did find that different cutoffs for women led to an increase by 42% in identifying women with episodes of heart disease.
Yeah. Wow.
So even understanding the sex-based differences in not just imaging, but also everything else that surrounds imaging, and
Hmm.
that helps us make a more accurate clinical decision making. That's also
Absolutely.
critical.
100%. And I like how you mentioned, none of these things kind of exist in silos. It is all like this collaborative effort. And I think on that note, would love if you could explain a concept to us, the idea of collaborative intelligence. Can you explain a little bit more of like what that is in medicine and how it kind of, I would imagine, really affects clinical workflows like we've been talking about?
Absolutely. Um, uh, so instead of, I will explain what collaborative intelligence is, but I will start from the very opposite end of it. Of
Okay.
some voices that are now saying that, oh, you know what, in 10 years from now, AI and machines will replace doctors.
Mm.
So that's the opposite of collaborative intelligence. And also, I don't think this is going to happen, not in 10 years from now. But but that's the opposite of collaborative intelligence. So collaborative intelligence means that uh, humans, as in the human doctor, uses AI tools to enhance our practice and our workflow, and help us take better care of our patients by at the same time reducing our burnout. Um,
Mm. Mm.
that's what collaborative intelligence is. Practically, what that means is, let's say that I'm using a tool to identify uh, people who are at high risk of um, valve disease of their heart,
Right.
maybe obstruction of valves or leakiness of their valves, or a tool that identifies people who are at risk of weak heart muscles, like heart failure.
Right.
Um, Collaborative intelligence means that this tool is very well integrated into my clinical workflow. It
Hmm.
doesn't, I'm not, I don't have to add more clicks to my clinical workflow. I don't have to open more tabs, more websites, more interfaces.
Right.
It is very well integrated into my clinical workflow, number one. Number two, has been co-designed with a clinician uh,
Mm-hmm.
who works with data scientists and with engineers and with ops specialists and with
Right.
patients and their families to co-design a solution that is meant to accurately and equitably identify patients from all different backgrounds, racial,
Mm-hmm.
sex, socioeconomic, cultural, with all different kinds of comorbidities at different stages throughout their lives. I will put an asterisk here and say, we know very well that pregnant women are traditionally excluded from clinical trials, so
Right.
we don't really have data to guide how to best care for pregnant women.
Mm.
Um, so with everybody, with all of the key stakeholders having co-designed this tool is very well integrated into a clinician's workflow.
Mm-hmm.
It provides with meaningful, actionable insights and not extra noise, not just data for the sake of data, where we don't have the bandwidth or the evidence to know how to use the data. So it
Right.
provides us with meaningful, actionable data.
Mm-hmm.
There's a clearly defined workflow that says that based on this is what happens.
Mm-hmm.
And importantly, there's post-deployment monitoring of this intelligent tool, meaning it is deployed and I use it in my clinical workflow, but there is a very well-defined oversight structure, like a committee or a
Mm-hmm.
group within my medical practice, whose job is to monitor the quality, the accuracy, the bias,
Yep.
the drift of this tool.
Right.
And And if I disagree with the output of the tool, I always have the option to override it. So there's
Yes,
always a human in the loop, always a
definitely.
human in the loop along every single phase of the tool's life, from
Right.
design to implementation and post deployment monitoring. And
Mm-hmm.
it's very easy for the end user, myself, to
Mm-hmm.
always override it and say, you know what, I disagree with this. I'm not going to follow this recommendation. Um, and here is why. Maybe there's an easy feedback loop where I get to say why I'm not following the recommendation. So to me, that's true collaborative intelligence, where the tool doesn't replace me, but it helps make my life easier when I work.
Yeah.
So when I get to go home, I can spend time with my family and not have
Yeah.
to do work.
Total
And
100%.
importantly, it leads to better outcomes for our patients. That's the North
Yes.
Star.
Yes, absolutely. And I love how you really kind of unpacked all of the different components that go into what this tool looks like, because I think it just goes to show like the level of thought that's required and that is, continuously needed for the maintenance, and how at the end of the day, it's kind of another like part of the care team almost, but it's not replacing anything. So I think you kind of walking us through that was very helpful. So thank you.
You're welcome. And
Okay.
there's actually an increasing number of statements and policies that are now
Right.
being published on this, like the Spirit AI policy and other such policies.
Mhm.
I'm happy to share with the community. Uh, in a few minutes, I can type it in the chat box. But yeah, there's a lot of policies that companies can use now, to the AHA, the American Heart Association, in
Mhm.
2024 released a statement. So there's a lot of really thoughtful releases that are now increasing in number to help the
Right.
companies and the health systems when they
Mhm.
adapt these tools to know, okay, now what? Okay, I have a tool or I've designed a tool. What do I do next? How do I make sure that it's it's not just performing well in the test environment. It's actually
Mhm.
performing well in the very messy
Real world.
real life clinical world.
Yes, 100%. And I think, Dr. Effie, on that note, I'm also so curious. We've talked a lot about the implementation, the design, really what the potential for a lot of these tools can be. But of course, implementing them, actually having them exist is a separate beast entirely. Are there any challenges that maybe yourself or your colleagues have encountered any barriers when actually introducing AI tools to the clinical practice, and would love your thoughts on some of the things you've seen and how you've kind of addressed those.
Yes. Um, so I will say that I'm not an engineer or data scientist, so I'm
Mhm.
not going to talk about challenges with, I mean, in theory, and I understand what some of those challenges could be, like data
Right.
drifting, biases that weren't in the initial design, but
Mhm.
we implement something in our real life practice. It's a different patient population that this tool is now facing and is asked
Definitely.
to handle. So there could be biases that unintentionally get introduced into the model. So there's a lot of very active monitoring in terms of performance of the model that's needed.
Mhm.
And not just based on AUCs, but based on net reclassification indices, decision curve analyses, and uh, stratified analysis based on different type of subgroups that traditionally have been underrepresented. So that's one part that has to do with the model performance in and of itself. But what
Mhm.
I would like to maybe focus a little bit more on is the human aspect,
Yes.
which has to do, if I had to label it, I would say change management. And
Yep.
we could have an entire conversation just like focusing just on that. But I think for everyone in our viewers and audience, it's easy to imagine
Mhm.
that it's hard to bring on effective change,
Right.
especially when there's so much real burnout,
Yeah.
clinician
Totally.
burnout. And I'm not just referring to doctors, but also nurses and our nurse practitioners, physician assistants, our techs. Um, there's unfortunately, there's a lot of short staffing
Yeah.
in all different types of specialist healthcare professionals.
Mhm.
And we're all being asked to do more with less resources.
Mhm.
And asking asking us on top of that to also learn how to use new tools that may or may not work, but let's
Totally.
see. That's honestly, that's asking a lot.
Yes.
I think that's the real hurdle right now, is that
Mhm.
even if it's a tool that performs great,
Right.
um, I think the real challenge is both for the company as
Mhm.
well as the health system that
Mhm.
examines adaptation and purchasing of
Yeah.
that tool. I think the real challenge is, okay, now that I have it, how do I actually get users to use it?
Definitely.
I think that's the real challenge, and we can talk about ways to mitigate that. I think it's going to be different. The right approach, I think, is going to be different for each type of practice.
Right.
A community hospital in a rural area is probably going to approach this much differently compared to University of Washington in
Mhm.
Seattle.
Mhm.
Um, but I think the main thing is to have early buy-in from the end users.
That's helpful.
So
Definitely.
having the end users, like the doctors or nurses or techs, have a seat at the table where the decisions are being made to purchase a tool to begin with. I think that's the first step, is
Mhm.
is having them offer their voice and listen to their voice.
Yeah.
Um, and then having them co-design the approach to get everyone else to buy in, and that could be helping us through brief everyday interactions.
Right.
I will speak from my personal experience. I don't have the time in my work life to carve out an hour or half a day for a session,
Mhm.
for an
Yeah.
education session on a new tool. It's not going to happen.
Yeah.
But if someone can join me, let's say in my clinic, let's say that I want to use an AI ambient scribe, um,
Mhm.
and I want to start using it. instead of having me sit through an hour or a half day long education session, it's probably going to be much better if someone joins me for an hour in clinic, not for my
Right.
entire clinic, just an hour in clinic, and says, okay, let me show you how you do this. And joins me
In
as
real
I
time.
work so that this doesn't interrupt my everyday work.
Yes,
Um,
absolutely.
and having feedback loops built into this,
Hmm.
so that if that something doesn't work, it's easy for me to give quick feedback, and to the leadership, and let them know that, hey, this didn't work well today, and
Hmm.
then move on.
Yes.
I think that's the real conversation, and I don't know if you, Nina, have any thoughts on this, because it's a tough
It
it's a tough
is.
one to figure out.
100%. And I agree. I think there's that problem is pretty universal of just burnout, change management. That's really kind of the piece of it. But the way it's kind of funny because I think your approach is really spot on, right? The way we talk about meeting patients where they're at, it's almost like we need to be meeting our care teams where they're at. And sometimes that's in the field, as they're working. So I actually think that's a pretty genius approach to be able to implement something. And I would imagine that just when they're able to see it in relation to their work and not just in a conference room somewhere, I would imagine that also speeds up the adoption as well. So it's kind of a win-win in my book.
Yeah. So we'll
That's,
see.
I don't, maybe we just started a novel new way of training that's now gonna sweep the nation.
I know.
I
But
love that.
it's I don't know, it's and we can talk more offline about this, but it's a little disheartening to think that there's tools that really work,
Yes.
but just because the environment and the system is not set up for adoption,
Hmm.
they're not making it to real life practice. Not because there's anything wrong with the tool or because we wouldn't want to use it, but the system is not set up for adoption.
100%. 100%. It was such a good discussion. Thank you so much for joining. We'll definitely have to do a part two to chat even further of all of the amazing work that's going on. But thank you so much for being here, Dr. Effie, and sharing your thoughts with us.
Thank you, Nina. As always, thank you to our Hit Love community, our Women's Health Tech Initiative. It's such an honor every single time, and I'm so energized. I can't wait for our next date.
Awesome. Thank you, Dr. Effie. Us too. Wanted to also give a quick thank you to our sponsors for sponsoring this conversation. And one last huge shout out to Dr. Effie for such a delightful kind of discussion about the future. And we will see you all next week. Bye, everyone.